a Whipple procedure in and of itself is an undertaking, but a robotic approach to it is, I think, a very highly specialized surgery. And so we have several surgeons who are, I would say, world experts in doing robotic pancreatic duodenectomies or robotic Whipple procedures.
This is the James Cancer-Free World podcast. I'm Steve Wartenberg, and my guest is Dr. Susan Tsai. Susan is a surgical oncologist who specializes in gastrointestinal cancers, and she was recently named director of the James Division of Surgical Oncology. Pancreatic cancer is a rare form of cancer, and traditionally, the outcomes haven't been that good for patients. Susan will fill us in on the new advances being made in the treatment of this type of cancer, including Whipple surgery, a complex and precise form of surgery in which Susan and the James are leaders. And she'll also fill us in on what's next in treating patients with pancreatic cancer. Welcome to the podcast.
Thanks, Steve. I'm really excited to be here, and I'm happy to talk on my favorite subject.
Okay. Skiing? No, pancreatic cancer and treating patients. So not only were you recently named director of the Division of Surgical Oncology, that's what brought you here, right? So fill us in on what made you decide to come here and what you'll do as division of the director of the Division of James Surgery.
Well, it was an incredible opportunity, and I think I'm indebted to Tim Pollack, who's the chair of surgery, who reached out to me for this opportunity. The Division of Surgical Oncology has a tremendous amount of talent, and the researchers there, both the clinicians and the researchers, are really leading the way in advancing what we can do for patients with cancer, with all sorts of cancers. And so I thought it was a terrific opportunity, partly because I'm committed to the mission of kind of advancing translational research, taking kind of bench to bedside approaches, and as quickly as we can treating patients of today, but learning and trying to advance our opportunities for the patients of tomorrow. So, and then of course, everyone knows that the James is a premier cancer institute, and it was just a fantastic opportunity to be part of that community.
And yet one of the things I've learned from Tim, who was on the podcast, and other surgeons, surgery has become incredibly more complicated and yet at the same time less invasive. It's really, you think that surgery has like reached its peak in what it can do, but no, not even close.
Yeah, I mean, I think that's the next frontier for surgeons. We have certainly trained in an era where we did maximally invasive surgery, but now we're starting to understand with better systemic therapies how we can marry the surgical aspect of that to provide the best quality of life for patients. And sometimes that means that we combine multimodality therapies, radiation, chemotherapy, and or immunotherapy with surgery, and we somewhat actually de-escalate care. I think that's very much been in the conversation for different cancers like breast cancer, how we can actually manage cancers more effectively with the least aggressive approach. And certainly in the case of pancreatic cancer, we're not exactly thinking about de-escalating care, but we have refined our surgical technique to be able to use robotic surgery in a minimally invasive way, and I think patients really enjoy that.
Okay, well, let's dive into pancreatic cancer, which you do every day. And so what is the pancreas? What does it do?
Yeah, so the pancreas is an organ that sits way in the back of your body. It sits right over your spine and your aorta, and it really does two things. It helps you regulate your blood sugars. So when people think about diabetes, that's some abnormality of the pancreatic endocrine cells that are working. And the other thing it helps you do is digest foods. So when patients start to have issues with their pancreas, it again either manifests as some irregularities in their blood sugars, such as diabetes, or patients can experience kind of greasy, oily stools due to malabsorption of fats.
Oh, so those would be symptoms that would lead them to go to their doctor, to lead them to go to a specialist.
They may be symptoms of problems with your pancreas, yes.
But it sounds like it also might be symptoms of other things which could slow down a diagnosis.
Yeah, exactly. I mean, I think pancreatic cancer in general is a relatively low incident disease. So if you think about colon cancer, there's maybe 250,000 new cases of colon cancer a year. If you think about pancreas cancer, it's closer to 60 to 65,000. So not as many people have that. So the regular screening recommendations that are in place for like colon cancer and prostate cancer, breast cancer, those don't exist for the general population for
There's
pancreas.
no screening, regular screening.
There's no recommended universal screening for pancreatic cancer, except in a select population of patients who are known to have a strong family history. In those patients, there definitely are very strong recommendations for screening. But in the absence of that, if you just think about the general population, there's not a way that we are actively screening for pancreas cancer. And as you were saying, the symptoms can be very vague. So you either have, oftentimes we look for new onset diabetes. So diabetes that's occurred within 2 years of a diagnosis. That's oftentimes one of the harbingers of pancreatic cancer, is that you have someone who maybe doesn't fit the typical phenotype for a diabetic. They're
like
not
by age or weight.
Yep, exactly. They're not overweight. That we're not kind of expecting. They're actually losing weight. So usually, I tell people with diabetes, the weight goes up and your diabetes gets worse, and you lose weight and your diabetes gets better. In the setting of pancreas cancer, it's actually a different type of diabetes, and it's actually related to the disease itself. So you may be getting worsening blood sugars, but actually you're losing weight from the cancer. So it's a paradoxical loss of weight, but a worsening of your hyperglycemia or of your blood sugars. So that is really should be considered a sign of pancreatic cancer until proven otherwise.
Now, you mentioned family history, which leads me to ask, can it be passed on through genetic mutations?
Yeah, I think we're starting to learn so much more and more about the hereditary risks. So when I was a medical student, we didn't think that there was any genetic background for pancreatic cancer, but now we realize about 10 to 15% of pancreatic cancers may be hereditary. And the most common cause, or the most common gene associated with that, actually is the BRCA2 gene, which is
the breast cancer
yes,
gene. Yeah,
exactly,
wow.
exactly. And that gene actually also places patients at higher risk for prostate cancer and other things. So we continue to evolve our understanding of these genes. But as I said, about 10 to 15% are hereditary, and either there are some known genes that are associated with that, but the great majority of patients may not have a currently known gene, and we know that it's hereditary only by understanding the family history.
So if inherited genetic mutations are, I think you said 15%, do you know the causes for the majority of the cases?
Yeah, so unfortunately, we don't. And I think that's the most frustrating thing when you meet a patient with a newly diagnosed pancreatic cancer. They always wonder, like, what could I have done to prevent this? And oftentimes we don't know what actually caused the pancreatic cancer. There's a couple things that we know are risk factors. So smoking probably is the single most important risk factor that we tell people. If you have a strong family history of pancreatic cancer, really try and avoid smoking or encourage them to have smoking cessation. Beyond that, the pancreas itself sometimes develops cysts. Like these are fluid-filled collections of the pancreas. Usually the pancreas is a solid organ, so we don't expect to find fluid-filled cysts. I always tell people that a cyst is to the pancreas like a polyp is to the colon. So it's
a warning sign.
It's a warning sign. It doesn't mean that you're going to have cancer, but it's something that needs to be followed and watched, because after a certain size, it may be recommended that you have that removed to prevent a future cancer or premalignancy.
And a cyst on the pancreas, once it gets to a certain size, people will feel some discomfort, will feel it?
No, and again, I think going back to the location of the pancreas being so deep within your abdomen, oftentimes, unless the pancreas is inflamed, there's really no symptoms associated with a cyst, with pancreatic cancer. It's kind of this very slow-growing and often quiet, or in terms of symptoms, disease.
So how do you diagnose it, or or what are the common ways in which it's diagnosed? How do people get to you?
Yeah. So the most common symptom that brings patients in is oftentimes jaundice. So the majority of pancreatic cancers, probably 60% or more, occur in what's called the head of the pancreas. That's the part of the pancreas that intersects with the liver, the GI tract. And so when there are some issues in that area, it's a very small area. So if there's a mass that develops, oftentimes we see a sign of that as a blockage of the biliary tree or the biliary system. And so patients present with oftentimes jaundice.
It's blockage between the pancreas and the liver, or
correct.
and
Yeah,
that's what,
or
okay.
the liver and the intestines. So things get backed up within the liver, and then patients become yellow or jaundiced. Oftentimes there's weight loss and abdominal pain, but these are pretty non-specific symptoms. But the jaundice is probably the single most easy thing to say. Like if someone presents with jaundice, then clearly there's a specific area in the abdomen we need to be investigating.
Wow, so with every cancer, we always talk about how early diagnosis is vital, but it seems with pancreatic cancer, that's a bit of a challenge, and that could lead to you seeing people with a little more advanced cases.
Yeah. I think even in the cases where we think that surgery is possible, so we have been doing surgery for pancreatic cancer for many decades, and we know what the outcomes are when we do surgery upfront for pancreatic cancer. In probably 70 to 80% of patients will have recurrent disease elsewhere in their body. And so when
the cancer is metastasized?
Well, after we take out the primary tumor, 80 to 80% of patients will recur, which really means that if we went in and we surgically excised the pancreatic cancer that we knew was there, and cancer comes back in 80% of patients somewhere else in their body, that really means that even when we thought we had a localized operable cancer, probably there was micrometastatic disease.
And that leads me to ask, because I'm trying to picture, so give me a sense of how big and the shape of the pancreas, and you can't remove the whole thing because people need that function in their body, right?
Actually, you can actually remove the entire pancreas,
okay.
and we do that on select occasions. We don't really like to do that because obviously having a pancreas has important endocrine and exocrine functions to help people digest foods and have control over their blood sugars. But it is possible to remove the entire pancreas, and we do that selectively. But to maybe getting back to your point, in terms of how do we change what we've been doing for many decades in terms of managing pancreas cancer? So one of my mentors and my former chair at the Medical College of Wisconsin, Doug Evans, really kind of pioneered this concept of changing the way we treat pancreatic cancer. Whereas in the older days, we would often rush patients to the operating room because obviously it's an aggressive cancer, and we were motivated to try and remove the cancer as quickly as possible. Unfortunately, because the recurrence rates were so high, it wasn't exactly maybe the best way to manage pancreatic cancer. These days, we understand that giving some systemic therapy up front to treat not only the cancer that we can see, but any invisible cancer or micrometastatic disease might have some benefit. And so he was the first person to kind of pioneer that approach, where instead of going straight to surgery, we would do some other therapy first, chemotherapy, chemoradiation, and then at this point, we've kind of done an evolution where in some practices, we do actually surgery last. It's what we would say a surgery last approach instead of a surgery first approach.
Wow, I've heard that from other people for different kind of cancers. That seems to be a trend that's growing.
For rectal cancer and yep.
Yeah, but we're going to take a quick break, and we're going to get back to that. You gave us a good tease about some of the advances in treatment, and when we come back, we'll really jump in and learn about a lot more.
The best outcomes for treating cancer come from early detection and early diagnosis.
The James Cancer Diagnostic Center at Ohio State
is designed to provide rapid evaluation and a clear diagnosis.
We are transforming care by giving patients direct access
to cancer experts who study and treat cancer every day.
If you think you have cancer, the choice is clear.
Choose the James Cancer Diagnostic Center.
We're back with Susan Tsai, and we're talking about treatment for pancreatic cancer. You gave a great overview of some of the biology and gave us a little hint about treatment. But let's talk more about the surgery and what you're now doing before surgery.
Yeah. So, Steve, these days we offer what's called a neoadjuvant approach for pancreatic cancer. And I think kind of contextually for the listeners and viewers is when we used to think about kind of a surgery first approach, the median survival after a surgery first approach is about 2 years.
For pancreatic cancer.
For pancreatic cancer,
Okay.
yeah. And so as we were kind of exploring these new ways to deliver therapy in terms of having upfront therapy rather than a surgery first approach, what we started to notice is among those patients who would start that process, they would get their neoadjuvant therapy and then surgery, we started to see longer and longer survivals. And currently it's almost double what we would see with a surgery first approach. And that's with our current chemotherapies and our available therapeutics. So as our systemic therapies actually start to improve, we may see that stretch out longer and longer.
Wow. So what does the chemo or the radiation actually do to the cancer in the pancreas that extends people's lives, that makes the surgery more effective?
So we're hopeful that when you get systemic therapy, it's not, as I said before, it's not only treating the cancer that we can see on the CT scan and we know that's there, but it can treat any other cancer that may be outside that area. And so giving an effective therapy early is very helpful in terms of controlling that disease. In addition, oftentimes we think about also adding radiation as well, because the radiation can help kind of control the tumor where it is, so that when we surgically remove it, the recurrence rates from the primary tumor being removed are reduced as well. So those two therapies kind of work in tandem to help us decrease both distant metastatic disease recurrence as well as local recurrences.
Oh, I hadn't thought about that, but the system-wide chemotherapy can effectively help your immune system find and attack cancer cells anywhere in the body that you haven't identified yet, so you can slow down or prevent metastatic cancer.
Yes, exactly.
Okay.
And I mean, the other flip side of this is actually going back to a surgery first approach, and we'll get into this a little bit, but the Whipple procedure, the fancy name that we often say is a pancreaticoduodenectomy, that operation involves moving part of the pancreas, but because it's in a high real estate area, we have to remove a bile duct and some intestines, sometimes part of the stomach, and then that is all reconnected. That is a very major surgery, the recovery from which about 50% of people after they've had that surgery cannot receive any additional chemotherapy afterwards. The recovery is significant, so that it's difficult to give additional therapy on the back end after surgery, but it's very easy to deliver that that therapy up front prior to surgery. So if we know that someone is at high risk for developing a metastatic disease recurrence, but only 50% of patients, if you have surgery first, end up being able to receive any chemotherapy, then that in and of itself is a limitation of that approach of a surgery first approach, if that makes sense.
So you have to determine that for each person, but what would make it so they can't get chemotherapy later? What happens in the body that you can't give chemotherapy again?
It's just the limitation of the impact of combining the surgery and then having to do chemotherapy afterwards. The surgery is there's a significant recovery from the surgery, and many patients who develop pancreatic cancer are often older. The median age is
it's
often
that
72.
The chemotherapy would impact quality of life and their ability to tolerate it.
Not exactly. Actually, it's just that patients really don't recover enough to be strong enough to even receive additional therapy.
Okay.
So it's that significant of a surgical procedure that it's very challenging to give additional therapy after surgery, but it's very well tolerated to give it prior to surgery.
Okay. Well, that leads, you're talking about complicated surgery, and that means Whipple.
Yes.
So what is this Whipple surgery that I've heard about a lot, and the name kind of stays with you?
Yes, yeah. So the Whipple procedure is a pretty complicated procedure. It involves removing the head of the pancreas. The head of the pancreas is attached to the first part of your small intestine, or the duodenum, so that has to be removed as well. And the head of the pancreas is also attached to the end of the bile duct from your liver, so you have to reconstruct the biliary system. And oftentimes, sometimes a small portion of stomach is removed with all that. So when the specimen comes out, there are 3 different systems that need to be reconnected. The intestine has to be reconnected to the pancreas, to the liver, and then to the rest of the intestinal systems or the stomach. So the operation usually is about a 5 to 6 hour endeavor. Usually half of the operation is removing that part of your body, and the other half is dedicated to reconstructing everything.
So this is how is Whipple different than how you did it in the past?
So the pancreas is actually, because it's deep in your body, it's actually adjacent to some very critical blood structures. And the pancreas itself, honestly, is a pretty finicky organ. It's designed to digest tissues. So when you're trying to recreate a connection of the pancreas to a part of your intestines, you obviously want your connections to heal, but the pancreas itself is trying to digest those connections. So it's kind of fraught with some peril, I would say, to begin with. So originally a pancreatic duodenectomy or a Whipple procedure carried about a 30% mortality rate. 30% of patients would not survive the procedure. Now, over time, there have been incredible advancements in surgical technique, and so now, at a high volume institution, the mortality is less than 3%. That's something that's very important for people to understand because it's such a complicated surgery. There are strong recommendations that those kinds of surgeries be concentrated at high volume centers where,
like here.
Yep, like at the James, where there are surgeons who really just specialize in that operation. They do it day in and day out, and they can manage the complications. They understand how to kind of most expeditiously kind of perform the surgery and take care of the patients afterwards. I think the differences that we have done that we've come across in the last 10 years that have helped as beyond surgical technique is sometimes we've been using radiation to help sterilize the pancreas itself before we surgically remove it. I think I mentioned before, this helps to make sure that the pancreas doesn't recur, or the pancreatic cancer doesn't recur after the surgery, so it minimizes local recurrences. But that radiation also serves to make the pancreas a little bit firmer and easier to sew to. And so the pancreatic leaks, where the pancreas juices are going where they're not supposed to be and they're causing some havoc, that actually decreases. That's the single kind of most feared complication after a Whipple procedure, is having a pancreatic leak. And those rates with the addition of radiation actually go from 20 to 30% down to 10% or less.
So I'm trying to imagine, because you said it's located in the back near the spine. So where would you make your incision and go in to get to it?
Yeah, so the incision is through the front of the abdomen. Which
means you have to get through a lot of things to get there.
Through a lot of things to get to the back. And I think amazingly, one of the advances that we've been able to do is I have partners here who are experts at robotic surgery, and a Whipple procedure in and of itself is an undertaking, but a robotic approach to it is, I think, a very highly specialized surgery. And so we have several surgeons who are, I would say, world experts in doing robotic pancreatic duodenectomies or robotic Whipple procedures, and so that, I think, is a tremendous asset of the program.
Clinical trials are always the way to the future, and I'm guessing that there's got to be something here at the James. There's so many clinical trials. Are you working on any in this area?
Yeah. I mean, I think this is a really exciting time for cancer in general, but also in pancreatic cancer especially. I would say one of the most significant advances we've had is the idea of being able to target a gene called RAS. So pancreatic...
Say that gene again?
It's RAS, R-A-S.
RAS, I've heard,
Yep.
okay.
Yeah, or KRAS is another word. So KRAS is it's an oncogene, meaning it's a gene that often drives cancer development. That gene is mutated in many different cancers. Particularly in pancreatic cancer, though, over 90% of pancreatic cancers have a KRAS mutation. So it is very, very important in pancreatic cancer. In the past, they have thought that this gene was undruggable. It was never going to be a target. It had to do with kind of the on and off rate of the enzyme activity, and it was, I think, impossible to be able to develop a drug that could target that gene. But the NIH had a RAS initiative where they really challenged our, best and brightest minds to approach how to target RAS. And somewhat out of that effort, and among some other independent work that was done, we have now a series of RAS targeting agents. So KRAS has that mutation, that gene has many different forms of mutation. But there are therapeutics that are being developed for maybe each individual mutation as well as a group of those mutations.
So multiple drugs.
Yes.
Okay, because there's multiple genetic mutations within KRAS.
Yep. Okay. So a single patient may have one mutation or another mutation. So the most common is G12D mutation. The first KRAS targeted agent was the G12C mutation. It was actually developed a little bit more for lung cancer. Very, very few patients with pancreatic cancer have a G12C mutation, but many have a G12D mutation. So those drugs are in therapy, are in clinical trials right now. So that's a very, very exciting time for us to be able to see how we can partner using now precision medicine, where we actually are targeting the tumor itself, with conventional chemotherapies, which of course target cancer, but also target your normal cells as well. So we're combining kind of this precision medicine and conventional chemotherapeutic approach. And I think that's going to be a really exciting advancement in pancreatic cancer.
Wow, that's pretty amazing. A genetic mutation that was considered impossible to target has now been targeted. Yes, exactly. Yeah.
So I think they always say nothing's impossible, right? So that is a really, for us, that's a huge achievement. On the aspect of operable disease, so the KRAS targeted agents are being tested in metastatic patients. On the operable side of the disease, we're really excited to hopefully open a clinical trial here soon, where we are actually using molecular profiling to try and determine which conventional chemotherapy would be best for patients with pancreatic cancer in the neoadjuvant setting, giving it before surgery. So right now, there are two main chemotherapeutic options, and we don't know which one is better for each patient. One could be better for you and one could be better for me, but really we don't know how to choose that at this point.
There's no test.
Correct. But coupled with that, there has been a lot of advancements in understanding pancreatic cancer in general, and we think there's broadly two major types of pancreatic cancer. There's a classical type and a basal type. This is not uncommon to other cancers such as breast cancer, colorectal cancer. There's these subtypes of the cancer where we can tell just by the proteins and the genes that are being expressed that even though it is a pancreatic cancer, it's a type A pancreatic cancer or a type B pancreatic cancer. That's the same concept here, where we're just calling it a classical subtype or a basal subtype. So a great investigator, Zhen Ye, who first characterized the two different subtypes of pancreatic cancer, also noticed that, interestingly, one subtype seemed to respond to chemotherapy and the other a certain type of chemotherapy and the other subtype did not. And so in knowing that, what we're testing in a clinical trial here is when we see a patient who's newly diagnosed with pancreatic cancer, we'll take biopsies. Those biopsies will then tell us what subtype that patient is. And based on that subtype, we're going to give a specific chemotherapy to see if we can actually tailor the chemotherapy to the subtype and if that improves outcomes.
So you're combining personalized and precision cancer medicine for one patient.
Correct. Yeah, for individual patients. So that is in the context of a clinical trial, and hopefully that trial will be open soon at OSU.
And so if this works, that means you'll be able to determine what chemotherapy to give patients, and knock on wood, you get better outcomes.
Exactly, because I think what's done in the clinics now is we choose one chemotherapy and we give it to the patient. If it doesn't work, then we switch to the other. So there's that trial and error, and hopefully this will expedite it so we don't have the error part of it. We just give the right chemotherapy from the beginning.
Wow. So you talked before about how some people are at higher risk based on family history. Mm-hmm. So I understand you have something for them. You have a high risk pancreatic cancer clinic here.
Yes, and that has been in establishment for a long time. It's actually a great resource for those who come to the James, and it's really led by Phil Hart, who's one of our gastroenterologists. But high-risk screening entails usually an annual follow-up either with an MRI or an endoscopy so that we can follow the pancreas for structural changes. In the near future, there also may be blood tests that we can do to help with early detection or early screening for pancreatic cancer, but those individuals who have a very strong family history or a known genetic mutation that puts them at risk for pancreatic cancer, those are the perfect people to be seen in this clinic.
So if they're seen in this clinic and screened regularly, the odds are you would catch it very early.
Very early, the purpose would be to catch it before there is a cancer.
How do you catch it before there's when it has those small growths?
Yep. If you have a cystic change that is starting to change and becomes worrisome, if you start to see any anatomic features, just to be able to catch it right before it becomes a cancer in a pre-malignant state, or catching it as an early cancer.
It's like a colonoscopy when you catch
Exactly.
precancerous polyps, remove them before they become cancer.
Mm-hmm.
Same thing on the pancreas.
Exactly.
Wow,
Yep.
it's amazing what's going on here, and that sort of leads me to another. You talked about this as one of the reasons you came here, to be at a high volume, comprehensive cancer center where with clinical trials, you must get people from all over to come here because you offer services that no one else does in the state.
Yeah, and I think one of the things that's very attractive to patients, if they're coming from afar and they're trying to expedite kind of their referral and workup here, is we do have a multidisciplinary clinic, and this is a clinic where in a single day you can see all the specialists that you would need and more. So it really takes a village to care for patients. It's not just the surgeon or just the medical oncologist or just the radiation oncologist, but certainly those three specialists are available. But there's also a genetic counselor who is present, physical therapy, a dietitian to kind of address the holistic needs of that patient all in one day. It can be a long day because there can be imaging that's involved, but basically patients will be able to come and have an expedited workup for pancreatic cancer.
This has been a great, not just overview, but we've really dived in, and it sounds like there's a lot of great things happening and that you're at the forefront of them, and that you came here to be even more at the forefront and to push things forward even more. So what drives you to do that, to take leadership roles, to create clinical trials, to do more for your patients?
Yeah, I think when you treat a disease like pancreatic cancer, it's very humbling because you develop these really close relationships with your patients and you really want the best outcome from them. So I think for me, we always think about our patients of today and how much we want to care for them, but we always think about, what if we could have done something a little bit more, and what's the next step? And just thinking about that patient of tomorrow, that's, I think, a huge driver of how we should evolve medicine, to kind of think about holistically how we can care for patients, not only, their disease, but also, the complete patient in terms of their ability to engage and return to the life that they had before the disease. So to me, that's very, very important. And that's the single most important thing for me in terms of pushing both the translational research forward, the clinical trials, mentoring young faculty, that it's always about the patient of tomorrow.
Thank you for joining us, and maybe you'll come back one day and fill us in some more.
Thanks, Steve. It's been a pleasure.
This podcast is brought to you by the Ohio State University Comprehensive Cancer Center, Arthur G. James Cancer Hospital, and Richard J. Solove Research Institute. For more information, check out our website, cancer.osu.edu.